Hi, my name's Matthew Links and welcome to this episode in the series Conversations in Medical Education. I'm the discipline lead in medicine at Bond University, and today I'm talking to Dr. Ravi Bala, who's a paediatrician. We're going to explore the issue of how to be an ethical practitioner with a focus on paediatrics. The purpose of this series is to explore those difficult areas of the curriculum where it's not so obvious how we learn. This conversation is part one of two. Today we're focusing on general aspects of ethics in paediatrics, and in part two, Ravi and I will consider the particular issues around child protection. Enjoy. Thank you for joining us, Ravi. Ravi's a paediatrician at Gold Coast University Hospital. And I'm keen to talk to him today about how you learn to be an ethical practitioner. We often think about how you learn clinical skills, how you do cannulation, those sorts of things. But learning to be an ethical practitioner is one of the more complicated parts of learning from your clinical placement. So thanks for joining us. Hi, Ravi.
Thanks very much for having me, Matthew.
So why do you think learning to be an ethical practitioner is important?
I guess you're right. You reflected that it's not something that we're commonly taught, and I reflect on my own experience as a student at Bond, and remember feeling like, the majority of what we're doing is really to learn clinical medicine and to, advance our knowledge and also prepare us for being an intern. But I guess the thing that we're not often being prepared for are those times when our own ethics or ethics of patients or ethics of the hospital system are being challenged. And talking from firsthand experience, being caught in the middle of a lot of those scenarios, as I'm sure you and others that watch this will attest to. It's really challenging when you have no formal training in it, or you've not really had the opportunity to think about it on your own. So you're kind of put in a position where you have to think on your feet, which is really challenging when you've got an ethical dilemma ahead of yourself. So I think ultimately the reason why practicing in an ethically responsible way and considering ethics whenever you practice is probably the most important way that we can protect our patients. In particular, when I think about paediatrics, we're dealing with a really vulnerable population of patients and families. So ultimately we do it to protect them and protect their families and family members and their carers. But I think it's also a really important way to protect ourselves as practitioners. Dealing with ethically complex and challenging cases is really, it can be anxiety inducing, because these are often the cases that end up in court proceedings or times when your judgments are put into question. Or case reviews or peer reviews. I reflect on my current experience. I attend a peer review, and our discussions are very rarely about complex clinical cases, because I think as you move through training and as you practice, you often pick those up and you learn your way through it almost independently. But the times when you're most challenged is when you've got an ethical dilemma in front of you. So yeah, I think it's incredibly important to remain ethically grounded, but to also have an approach to how to manage ethically complex situations, who you can turn to for advice, general strategies and approaches, and to really immerse yourself in it early, because the next time you're immersed in it might be you on the receiving end. So be prepared.
Yeah, I mean, you make a couple of really good points there that I'm keen on. The first is that point that you don't just suddenly get born into being an ethical practitioner. You've got to learn it, you've got to practice it and think about it early. And the other is the link to well-being, both for patients and our own well-being. So reducing that stress, I think, and preparing strategies, etc., that help you reduce that stress, that's a link to our well-being. So that really highlights to me how important this topic is. Do you have some examples, some sorts of areas of paediatric practice that you think are the most challenging or most often create challenges in ethics?
I think there's lots. I think there's a couple of ones that definitely spring to mind. So probably the first one to discuss is around consent. So in the pediatric population, it can be really difficult to know what the appropriate way is to approach consent of a patient. First question is, who do you actually consent? You know, in a patient that is young or pre-verbal, understandably it's going to need to be a parent, but sometimes it's not the parent. Sometimes there might be other people that are involved in medical decision making for a child. So knowing who to consent and when to consent is a really important aspect of clinical medicine that we don't often think about. You know, we see a child who's sick, we know what the treatment is, we prescribe the treatment, but we don't actually know, in a lot of cases, who is the right person to be getting consent for the treatment. Which brings into question, I guess, the flip side of this is, you know what the patient needs to get better, and you need to get consent in order to do that treatment. But what if whoever is meant to consent for this child, or the child themselves, does not consent to treatment? That's often a position that we're negotiating in the pediatric sphere. We've got a patient who's sick, and we've got someone who's advocating for that patient, who is in most cases a parent or a close carer. In some cases it's neither, and sometimes it's the Department of Child Safety or another organisation. So it's really important that we as practitioners learn to communicate with families in a way that allows them to understand what the child's clinical condition is. This is what the treatment is that would allow the best results. These are alternative treatments that could be utilised, and this is the effect if the treatment is or is not followed. But despite doing all that, sometimes you do run into issues where patients or family members or carers will refuse treatment, and that's a really complex area to figure out. How do you move forward from that? So that's something that people that are listening to this, I just want you to think about that in your own clinical practice. What if the next time you see a patient, they refuse your treatment plan? How would you approach that? How would you communicate? How would you document? So that consent is a really important issue in pediatric medicine in particular. The second one is navigating complex family dynamics. When we're seeing a patient, we really have to, as part of that biopsychosocial model of care, we really need to understand this patient's social context. I reflect on my own experience. I have an intact family unit. I have an older brother, and I've had parents that have now been married for almost 35 years. So I reflect on that and I go, okay, things were pretty straightforward for me, and I imagine people that were interacting with my parents for the care of me understood that quite well. That's not always the case. We have separated families, we have stepfathers, stepmothers, we have, especially in the case of culturally and linguistically diverse populations, we might have other family members or friends that act as a caregiver for the child. So it's really important to understand that family dynamic, so that when we're communicating with families, we know who we're communicating with, we're communicating appropriately and effectively, and that's going to allow that whole biopsychosocial model to work really effectively for the child, and maintain that really nice relationship with our patients and families moving forward in their care. And I guess another common area where ethics really comes into play is dealing with the older child. So this is a child that might be, 10, 11, 12, older, and most commonly in our adolescent population, which we currently define at the hospital as if you're 14 or above. These are patients that in most cases are intellectually able to understand their condition. They're able to have clinical discussions, and they're able to consent for therapy in a lot of cases. But then we've often got a family member who wants to be part of that dialogue, who wants to be part of that decision making. So it's a complex fielded discussion when we have to respect the older patient, but also respect their parent or their caregiver. And what happens when there's a disagreement between what the patient wants and what the family wants or what the carer wants. That's a really tricky area to go into, especially in a lot of practice for paediatricians, and currently at Gold Coast University Hospital, we deal a lot with adolescents, and we have at our hospital, because we've recognised the need for that really tailored care, we've got an adolescent and young adult unit. So a big part of taking histories and examining and giving therapy for adolescents along with their medical care is understanding their psychological and their social components and factors that influence their health. So a common tool that we would use would be what's called a HEADS assessment, which is a structured history which kind of explores their psychosocial determinants of health. So, you know, talking about their home life, education, activities, drugs, self-care, sexuality, suicidality. These are really complex issues to discuss. And it's really important that we have that opportunity to build a relationship with the young person, to have that conversation in private. But we've also got a parent that is highly invested in their child and wants to understand as well. So there's also that interplay with how do we take these histories and perform these examinations on our young people whilst maintaining respect for them, but also for their family who are very invested in their care. So those are just kind of three big issues that I see in paediatrics that we deal with on a day-to-day basis that we always have to keep in mind.
Yeah, these are very familiar to me in adult oncology. And the thing I love about this discussion is that the paediatrics provides an exemplar of these issues about person-centered care and shared decision making and inclusion of family, etc. But the application of them is very broad. The lessons you learn in your paediatric term about this can, you know, well apply negotiating a complex contested family in oncology or adult medicine. So these are, you've highlighted one of the dilemmas, I think, for us, which is that the ethical dilemmas are the hard end of the medicine spectrum. And often when I'm asking students to learn something and say, oh, you know, go out, practice it yourself, do a respiratory examination sort of thing, you can't ask them to go out and negotiate the treatment in a contested family or how do you suggest that we maximise the learning that students can have about these issues when their role is limited by their juniority? That's a word.
Yeah. So it is really hard to teach and to practice ethical medicine, and sometimes, as we highlighted before, it's not until you're in that situation that you actually have the opportunity to practice, but you also have to prove yourself at that time. So it is really challenging. And I guess my advice would be to really get stuck into your rotations. You know, when you're doing your clinical placements, these are the times when you actually get to observe this stuff happening. And it's not just a matter of observing and watching and seeing how the clinician interacts with that patient or performs that consultation, but it's about taking that experience away and then maybe at some point having the opportunity to reflect on how it went. Can you still see me, Matthew?
Yes.
Sorry, the screen just blanked for a second for me. So take the time to reflect on that case when you go home, or maybe when you're trying to fall asleep, as often these reflections come to me, is what would I do if I was in that situation? Would I have handled that the same way? would I have communicated in the same manner? Are there things that I would have done maybe a bit better? Or if I was going to find that really challenging, really sit with that uncertainty, because the next time you're facing it is potentially going to be you, and it might be years away. It's not going to be something that you get to practice in the next few weeks while it's still fresh. So sit with that worry, that stress, that anxiety, that feeling that it gives you, because I think that's a really powerful motivator for us to create change for ourselves. So push yourself, and it doesn't mean that you have to practice having these discussions as a medical student or even as a junior doctor, but it will be you. And I think it's important to just think about it. You know, it doesn't need to be long, but it just needs to be a practical, honest discussion with yourself about how you do it. Put yourself in the shoes of that clinician or that family member. In particular, when it comes to paediatrics, it's always a good idea to familiarize yourself with some of the legalities around paediatric medicine and practice. So, you know, think about what the consent laws and requirements are. So if you're working in a Queensland health facility, there's a whole intranet page that is dedicated to how to obtain consent, who to obtain consent from, and how to troubleshoot consent issues as they occur. In particular, in the paediatric population, we often talk about Gillick competency. So have the opportunity to understand that original case that happened, you know, decades ago, but also kind of think about how it might apply to day-to-day practice. And the final aspect that I think is really important for any medical student or junior doctor to be really on board with is child protection. So being aware of the state-based child protection laws. So those are kind of some important resources that are out there and that are available. And the motivator for accessing those sources is going to be that ability to observe what happens in day-to-day practice and have the opportunity to reflect on it in your own time.
So there's, I think that making the most out of the chance to observe and highlighting reflection as a key part of that. And we often do reflect in the middle of the night, worrying about the really impactful things that we have seen. I guess the other thing that there's a couple of other things which might be possible. And one is just for, you know, for the students to explicitly question about the process that's happened. You know, like when you've got that thing, say to ask the consultant, you know, that was really difficult. What the how did you go? How did you think about going about that? What helped you deal with that difficult situation? I noticed that you put the family at ease before you went into the more difficult part of the conversation, etc., to, you know, really try and foster a conversation. And I think supervisors also have that, you know, role fostering the conversation. The other is to give yourself the tools to be able to explicitly name what happened. You know, to be able to analyze that conversation, reflect on that conversation, but to have the words to be able to say, oh, that was validation. You know, I noticed the consultant validated the child's perspective on this, etc. So I think it's interesting, I think, as to how we can promote the learning in those conversations, promote not just the reflection, but the interaction and conversation about them. And then, you know, doing that with the supervisors is part, but also peers. You know, I really would love the idea that students will be talking to each other, processing what happened in their homes, getting some feedback or some, you know, orientation around what's happened, some reality checking about what's, you know, so there's a lot. I think there's a lot we can do, but it's not always so obvious.
I think your point about getting the students to approach the clinicians to kind of reflect, you know, have that real-time reflection on things is actually really helpful, because I think as clinicians, we all want validation You know, did I actually do that well? And we often don't get the chance to reflect in a more formal sense or reflect with our peers. And I think students absolutely form part of that team. And, you know, if a student came up to me after a challenging discussion and asked me, you know, how did you find that? You know, I noticed you did this, I noticed you did that, you know, any tips that you have if I was in that position? I think that's really validating for the clinician as well. And it allows that honest, open dialogue and discussion. It doesn't need to be a formal thing, but I think it's a meaningful discussion, and it's a meaningful moment for not only the student, but also for the clinician.
Well, there's been some gold in your recommendations there. I really appreciate that. Is there any last comments or last words that you would put to our students to about learning ethics in practice?
Yeah, I think this is something that takes time. This is something that doesn't have a syllabus. It doesn't have a curriculum.
Yep.
There is no time pressure on this, and it often sneaks up on you. And I think just being aware that it's out there and having that opportunity to have that reflective capacity is really important. Be prepared. Internship is the time when your stress level increases significantly as the amount of knowledge required increases, the amount of requirement from you as a person and as a team member increases significantly. The last thing you want is for an ethical dilemma to really shake what is already a pretty full-on and challenging but rewarding time in your clinical life. So the journey can absolutely start and should start as a student. And if I could go in a time capsule and talk to myself when I was a student, I'd say be prepared. There's going to be some times when your practice is going to be challenged. Your ethics and your morals and your values are going to be challenged, and be ready for that.
Well, I think there's been a lot. Thank you. There's been a lot of gold there. I think identifying the issues of consent and complicated families as being areas to really focus on. Students can build their skills in the simple encounters, so that as part of the preparation for the complex encounters, and with those complex encounters, being able to observe, reflect, ask questions, and go away and do the research about the information or policies or legal aspects that inform that encounter. That's a really good practical advice on how they can learn from these situations, and your highlighting of why it's important is, I think, also a really important step. So thank you very much. I hope our listeners have taken some of those gold away, and if they're interested, I'd encourage them to look at the other episodes on our podcast for similarly informed discussion. Thanks very much, Ravi.
That's great. Thanks so much, Matthew. Appreciate your time.
Well, I hope you enjoyed that conversation and are inspired to learn more about learning ethics in practice. Listen to part 2 of this conversation, where I discuss with Ravi the difficult issue of child protection, or listen to the other videos in this and a related series on Vimeo. If you're a Bond student, look up resources on the Learning in Practice page on iLearn, and here are some video and journal resources that you might find useful. Good luck.